Welcome back to the Journal of Oncology Practice podcast from ASCO. I'm Dr. Bob Miller, medical oncologist at Johns Hopkins and consultant editor at the JOP. The July 2011 issue of the journal is a special thematic issue devoted to electronic health records in oncology. If you're a physician in the United States in 2011, you're very likely at some point along the spectrum of considering implementing and or using an EHR in your practice, so it'd be pretty hard to escape the term meaningful use. To help us make some sense of all of this, I'm pleased to have as my guest one of the guest editors of this JOP EHR issue, Dr. Peter Yu. Dr. Yu is a medical oncologist and director of clinical research at the Palo Alto Medical Foundation in Sunnyvale, California. He's a member of the ASCO Board of Directors and chair of the ASCO Health Information Technology Workgroup. He's also the author of the lead-off article in this JOP issue, Why Meaningful Use Matters. Thanks for joining me, Peter.
You're very welcome. It's my pleasure to be here today.
Okay, who holds the trademark for the term meaningful use? I wish I were that guy.
Right. It's one of those terms that have become ubiquitous in use, and at this point, no one really knows who started it and what it actually means, although everyone has some concept of what it's supposed to be. I think of meaningful use as the use of information technology to improve quality of care and efficiency of care. And I think that there's an underlying principle which distinguishes an electronic health record from a paper chart. The vendors who create electronic health records, unfortunately, I think often don't understand that. Mm-hmm. In fact, if you talk to them, they often tell you that when they design their electronic record, they take great pride in that they try to follow a paper chart, mm-hmm. so that the doctor would feel very comfortable using an electronic chart and not feel as if this was something very foreign to them. Unfortunately, I think that type of thinking constrains your imagination as to what an electronic record can actually do. An electronic record should be more than just an electronic version of a paper chart. It should actually be a tool that can be used to actively take care of patients. It's a tool in which you place orders, in which you review data, in which you analyze data, you communicate with other doctors, you communicate with patients. And I think that concept is what we really mean when we talk about the meaningful use of electronic records.
I want to ask you a little bit about the national scope. It's easy to get confused with all of these terms, all of the policies and organizations and these acronyms, ONC, HITECH, FACAS, RECs. Just tell me, who are all these people?
Right. Who are those guys? I actually think it's not necessary to get so enamored of all these names and abbreviations. There are some that one should know about. I would start first with the Department of Health and Human Services, which is a cabinet-level department within our federal government. And it's really, Health and Human Services is really the department that runs everything that involves doctors, from the FDA to CMS, which pays Medicare, our Medicare bills, the CDC, all are housed under Health and Human Services. One of those departments is called the Office of the National Coordinator for Health Information Technology, or ONC. This was initially a presidential decision, which became codified as a formal standing part of HHS during the Obama administration. And it works closely with CMS and another three-letter acronym, IOM, to help establish healthcare policy. So ONC is an important player. Mm-hmm. The Office of the National Coordinator was charged with coming up with the underlying principles behind the meaningful use incentive dollars. So it's important to understand them. CMS is important to know because that administers Medicare and Medicaid, and we all know that. It pays the bills. And so the incentive dollars actually come through the CMS reimbursement mechanism. So they have a role to play in all of this. And the Institute of Medicine, as I said, comes up with much of the intellectual thought process that goes into driving how ONC thinks about constructing meaningful use incentives. In terms of legislation, the ARA stimulation bill, which was designed to help us out of the Great Recession, And when they were building all the incentive dollars and trying to figure out how to stimulation dollars rather, and trying to figure out how to get the economy going, a fair amount of it was designed to go into healthcare. And there were portions of the ARA stimulation bill which addressed healthcare. And collectively, those portions are often referred to as the High Tech Act. So you may hear high tech, and basically that is part of ARA, but it's referring to those parts that relate to the stimulation dollars. That's the legislation that establishes the criteria that will be developed in 3 stages for the stimulation dollars. That's to be not confused with the Affordable Care Act. So the Affordable Care Act is the Obama administration's legislation which talks about healthcare reform. And I think that's an important distinction to make because the Affordable Care Act is obviously under some degree of attack and is subject to revision. So those aspects of the Affordable Care Act may not be here in a year or two, but that does not affect the stimulus dollars that go into meaningful use. That's in a separate piece of legislation, and there's no discussion about changing or taking that away.
So that's safe, no matter what happens with the current congressional discussions, that those dollars are
exactly. All the discussions about balancing the budget or cutbacks are not targeting the meaningful use criteria.
Well, I'm sure that's reassuring to a lot of people. In your paper, you talk about how the Institute of Medicine principles underlie meaningful use objectives. Those are some pretty lofty goals. What are the real practical implications, though?
Well, absolutely. The Institute of Medicine is, if you will, a think tank that conceives the big picture of where healthcare reform needs to go and advises the federal government and Congress on where it should be moving. That's its job. But it thinks on a very high level, and translating that into reality is not something that they actually do. It falls, as I mentioned earlier, into the Office of the National Coordinator to take the first step of translating those lofty goals into real practical, actionable events. And then ultimately CMS, which is the one that pays the incentive dollars or in the other case puts in the penalties for noncompliance, that does the final arbitration. But the Institute of Medicine has come up with 5 overarching goals. That's their term, overarching goals, for how information technology can transform healthcare in the United States. Of those 5 goals, 4 of them are directed towards healthcare, and the 5th is more of a, I would say, technical goal, which deals with privacy and security information, which is critically important, but not directly improving care. So let's focus on the first 4. Number 1 is improving quality, safety, efficiency, and reducing healthcare disparities. This really talks to improving care to patients. And anything that an electronic health record can do to improve safety and quality would fit into that. I think one of the prime examples that would fit oncology would be chemotherapy ordering. Having orders that are unambiguous, that cannot be misinterpreted, that are ensuring accountability. So the author of the order is established. The checkpoints along the way between pharmacy and nursing are well established. The ability to build these checks and balances pretty much along the principles of the ONS and ASCO principles for safe chemotherapy administration would be a perfect example of how an electronic record can streamline care and improve quality and safety and efficiency. It really involves several aspects that touch on to how an EHR impacts clinical care. It involves accountability, transparency, communication, as well as what we often call workflow redesign. So an electronic record requires you to think about how you go about the steps in the process of ordering chemotherapy in this example. And it makes you think about the different ways that it could be done within your practice, how different doctors and different nurses approach it. And it forces you into trying to come up with a consensus best practice policy, which could be called workflow redesign. So these are all aspects of healthcare delivery that the rigor of an EHR will force you to address. The second meaningful use overarching principle is engaging patients and families. And clearly, oncologists do this all the time. But electronic health record can make that easier through tools such as patient portals, patient educational material that can be with one click printed out, treatment summary and plans, which are documents that help the patients to understand what the plan is, after visit summaries that can be printed out after each visit, which have the bullet points of this is what's happening next, this is what we discussed, these are the tests to do, can be very helpful. The third overarching goal is improving care coordination. And oncology is nothing if not a multidisciplinary disease with radiation therapy, surgical, primary care, medical oncology, as well as allied health professionals such as social workers and nutritionists, and improving the coordination of care so that there's not waste in the system and not mixed messages is very important for improving quality care. And the final one is somewhat vague. It's called improving population and public health. And it actually took me quite a while to try to figure out how that applied to oncology, since we think of that, or I think of that more as infectious diseases and disease control.
Sure.
This really goes to a broader concept of improving healthcare across the nation on a population basis and improving quality of care through instruments such as guidelines. So when ASCO or NCCN or someone else comes up with a guideline, really what that organization is saying is across the United States, across the entire population of people with stage 2 breast cancer or whatever you want, that this is a practice guideline that in most cases is probably the right thing to do. Not all cases, but most cases. And when an organization does that, it's really addressing the nation's population for that healthcare disease segment. And I think that really relates to a lot of what our organizations do in terms of issuing guidelines that are practical, that make sense, that are not just fluff and not just theoretical, but actually lead to important treatment decisions, and that can be measured against. So we can measure quality, so we can improve quality. And those are very core values to us these days.
So you note that CMS is the final arbiter for the meaningful use criteria, and it's pretty clear that if it weren't for these fairly generous federal incentive dollars, there may not be anywhere near the interest in meaningful use. Again, on a practical level, what do oncologists need to know about qualifying for these incentive payments?
Again, you're absolutely right, and I would say it's a carrot and a stick. So right now, we're fortunately in the carrot phase where we have these incentive dollars. But by 2015, if you are not participating in meaningful use, there will be a 1% reduction or take back from your entire Medicare-based reimbursement. And the following year, it goes to 2% and then to 3%. So there's a stick out there as well. Right now, it's important to talk about the carrot, but there's also a sense that, or this need to understand that if you don't think that carrot's too attractive and you ignore it, you're going to be facing the stick in a few years. But it is an attractive carrot. It's $44,000 through Medicare. You can also qualify through Medicaid, but 30% of your patient population has to be in Medicaid, and that is not necessarily unattainable for many pediatricians, but for adult oncology, that's generally not going to be the rule. So mostly we're talking about the Medicare qualifying requirements. There are two components to that. First, you have to have a computer system. You have to have electronic medical record. And it can't just be any. It has to be one that is certified by certain certifying bodies that Medicare has designated to do the testing, to look at the product, to test the vendor and say, yes, this product can actually deliver on the goods. But that's necessary but not sufficient. You also then have to show that you actually know how to use it. And that is where that term meaningful use again comes up. So it's the meaningful use of this certified technology that you purchased. So what does that mean? Well, one means that you have to buy the thing and you're not getting the incentive dollars just to buy it. So you have to have a capital outlay to get that in your system. And then you have to learn how to use it in the way that Medicare wants you to use it. And then you have to prove to Medicare that you did that. Initially, you prove that by attestation, which means you simply say, you're on a stack of Bibles that you did this. Eventually, though, when Medicare or when CMS gets its electronic systems implemented, it will require that there's direct reporting, so they actually know from your system, the feed out of your system, that you're actually doing it. So what are these hoops you have to jump through? Well, they are going to be released in 3 stages. Each stage will, as you might expect, be progressively more demanding, but initially there's a lower bar which rises, and approximately every 2 years there'll be the next stage will come out. Right now we're in stage 1. 2011, this year, is the first year of stage 1, and next year as well. And if you participate in the meaningful use incentives and qualify either this year or next year, you will, and continue to proceed through the next 2 stages on schedule, you will ultimately get $44,000. It'll be paid in increments in each year, front-loaded increments, more in the first year than the last year. If you delay beyond 2012, then you won't get the full $44,000. The clock is ticking, and the amount you receive will be less for each year that you delay past 2012. So 2012 is really the year you got to get going. There is a substantial benefit in the first year. The first year, the government says you only need to participate for any 3 months in the first calendar year. It could be the last 3 months. It could be the first 3 months. So they're giving you multiple chances in that first year to get it going. But after the first year, you'll have to meet the criteria for the entire 12 months of the year. So that's one important thing to know. There are 15 core criteria that you must meet, and you have to meet every one of these 15. In addition, there's a menu, as it's called, of 10 other criteria categories, and you get to pick 5 out of these 10. So you have a total of 20 categories that you must comply with in order to meet the meaningful use incentives.
And you said it's 100% compliance. You have to hit every single one. Is that correct?
Well, you have to hit each one, but each one is not necessarily 100%. So, for example, for electronic prescribing, so there's a requirement that you use the system to order drugs electronically to the pharmacy for a patient. But it's not 100% of all patients. The bar is actually 40% of patients have had at least one electronic order submitted. So within the category, there's a number that is set on the low side. And in stages 2 and 3, that number will inch up. So that's one way to increase the bar within stages, is to increase the threshold level. Another way is to add new criteria, and they will probably do both. Of those 15 core, one of them has to do with quality measures. And I'm anticipating a question you're probably going to ask, which is, how relevant is this to oncology? And this is a part answer to that. So in that segment for quality, they went to the PQRS quality measures that were endorsed by the National Quality Forum. That's a separate CMS incentive program for quality called PQRS. Used to be called PQRI, and they simply adopted those. Now, if you've had experience with that program, you quickly realize that there's very few quality measures that are relevant to oncology. So that is something of a stretch for oncologists to do. I think it's doable, but it requires a little bit of innovative thinking, I think, to meet that.
So the quality measures that are available to oncologists, you're saying there are specific quality measures that fall within our specialty. Does that mean that you can rely just on those quality measures, or do you have to pick some type of primary care measure like smoking cessation or vaccination?
Well, you have to do some primary care. So the quality measures, again, they gave kind of this menu, this somewhat complicated menu process, a little more complicated than it had to be. But there were 6 quality measures that you had to pick at least 3 out of these 6. And so they are adult weight screening and follow-up. So this is really addressed towards obesity, one would assume. Hypertension, blood pressure measurement. Well, that doesn't have a whole lot to do with oncology. Obviously, if you're giving someone bezacivimab, you should measure their blood pressure. But you take a blood pressure on everybody when they come in for a visit, so it's not difficult to do. It's just not terribly relevant to oncology as a quality measure. So some of these influenza immunization, certainly anybody on chemotherapy or with altered immune status should get influenza immunization. So you can live with that. But end of the day, is that really an oncology quality measure? Certainly not.
It's a little bit of a stretch.
However, I think that as stage 2 and 3 progresses, the quality measures will begin to, I think, focus more on specialties. That's clear. One of the things that ONC told us oncologists who work with them was that stage 1 is about primary care. That's really where the money is from their perspective. That's where the greatest impact of electronic health records will be on primary care rather than surgical specialties. That's where the greatest potential to impact cost of care will be. And so they designed stage 1 for primary care. Stage 2 and 3, they promised they would begin to look at specialty care needs, and that we should tune in again to see what happens in stage 2 and 3.
So you've personally been involved, of course, with ASCO's activities in this area for several years, and you're finishing your term on the board of directors. Tell me a little bit about the role that ASCO has been playing or is expected to play in the future when it comes to really any of this, to meaningful use and EHRs and just some of the long-term strategic things that that ASCO is up to in this area.
Certainly. Well, ASCO is doing what it always does, in response to the federal government. Whenever CMS makes a change in its policy, it's required to publish that in the Federal Register and solicit public comment. And ASCO always submits letters once it studies the proposed regulations. But there's something very different about meaningful use. It is so novel and so out of the box, and the intent is so global that you really sense that CMS is actually listening very intently to what people say. They really don't know how this should look, and they've been told by federal legislation to make it happen, and they are trying hard to make it happen right. For example, I mentioned there was 15 core requirements or hoops to jump through, and then a menu choice of 5 out of 10. Well, initially they just said everybody's got to do everything, and there was enough hue and cry saying, we can't do everything. There's specialists out here who just don't do this stuff, and so they backed off and said, okay, well, these 15 everybody should be able to do it, and we'll give people a choice of the other stuff. So and they've lowered those thresholds from very high standards, and they've got rid of some they just threw out the window. So that's one role. But I think you're asking me something else, or at least I want to get to something else, which is what we call a rapid learning healthcare system. So ASCO and ASCO members have, including myself, have been invited to attend some of the Institute of Medicine workshops on constructing a digital infrastructure for the nation. And this is a much more powerful long-range view where all these different electronic medical records in every doctor's office, and the meaningful use will get us hopefully to a point where there'll be an electronic medical record in every hospital, in every doctor's office, and it'll be a certified system that can exchange information with other systems. So there's what sometimes we call data liquidity, and a patient's information can be passed from their surgeon to their oncologist. If the patient moves across the country to get a job, the next oncologist can just pick off from where the first oncologist was. And so there'll be this national infrastructure where data can flow. The Institute of Medicine's broader concept is once that is obtained, we can begin to mine or analyze that data with the intent that every patient's experience, that the data from every patient's medical problem and response to treatment tells us something that we can aggregate and not replacing the clinical trial by any means, but supplement the clinical trial. So there are some questions which can't be answered in a randomized clinical trial, but could be answered this way. And so this idea of taking the information from every patient, learning from it, creating a better guideline or creating a better treatment or a better, broader reimbursement will then lead to some actionable event that will then in turn change the system. And then you go back and measure and see were the outcomes better. So it's measuring, collecting the data, analyzing it, and measuring outcomes, and doing that not as a one-time process, but iteratively, leads to what's called a rapid learning healthcare system. And we want to, ASCO would like to take this concept and be one of the first, if not the first, specialty to show how this could be done for the rest of the nation. And ASCO has, as you know, set as its strategic policy to develop this concept going forth. This is something new that ASCO board of directors adopted just this past March. We are reorganizing our departments within ASCO, hiring new people, develop expertise where we need it. And in the next 2 or 3 years, you will hear a lot about how this develops.
It certainly sounds like, a terrific idea. And like I think I've said before, it's the way medicine should be practiced. It's just we've had so many barriers. But it's hard not to be a little bit cynical, I guess, knowing that oncology is still practiced largely in small practices. And although there's consolidation is growing, we still see modes of practice that have been the same way for many, many decades. So my question really is, how practical do you think this is? Are we going to be seeing examples of rapid learning systems, say, in the next 2 to 3 years, or is this a 5 to 10 year timeline?
Well, whenever you start a big new project, in my experience, you always look for low-lying fruit because you know that if this is to be successful, you have to demonstrate early on some practical value to it. Even though you know in your heart of hearts, this is a long-term project that's going to transform healthcare for a long, long time in the future and will be an ongoing project. Nevertheless, you need to find something early on. Mm-hmm. So how I interpret that, for ASCO is we've looked at some of our programs and found them maybe a little bit lacking. So our guidelines are based on what's called systematic review of randomized clinical trials, and they are scholarly efforts in a field for which there's quite a bit of knowledge already known. However, a lot of times people have already made their decisions about that data, so you're often not telling people something that they didn't know before. And it narrows you to a very, very, very limited question that doesn't address the broad issues or the controversial issues of that disease and doesn't lead to outcomes measurement to show you actually improved anything by doing it. And so one of the early steps we're going to take in ASCO is to look at our guidelines development process. We're going to look at how do we select what guidelines we develop. It shouldn't not just be based on, well, we know a lot of information about this so we can study it. It should be based on, well, where are the issues that the oncologist in practice really wants guidance? And even if the data is not there, the rapid learning healthcare system will find a way to fill that knowledge gap so that the guidelines can be constructed and not as a definitive academic perfect statement, but as a work in progress that the rapid learning health system will allow you to iteratively improve. And so we're working right now with the Guidelines Committee to try to identify a couple guidelines that we can demonstrate as a pilot project, that kind of concept. Another area is COPI, which is the way or the mechanism that ASCO gets information from practicing oncologists about how they're treating certain patients. And so it's a method of receiving information from oncologists. Now, right now, we don't analyze that data beyond simply telling people they did or did not do what we think is the right thing and how they compare to their professional peers. But if we actually begin to look at that and use that as a source of data to see what is happening, that can inform us about the guidelines. And so I think this redesign of how ASCO produces guidelines and how it uses COPI with its members, this is something that I think will happen in the next year or two. There is one point I'd like to make about the $44,000 incentive dollars. We've talked as if that is a large sum of money, and it is a large sum of money. The government doesn't very often give you tens of thousands of dollars for doing something that you might have done anyway in a different way. But in terms of the cost of licensing or purchasing an electronic medical record system, the cost of buying servers to store the data or monitors and printers and setting up a wireless network in your office and setting up a patient portal and then training your staff makes that number pale. So I think that while, and as I said earlier, you still have to put that capital outlay. You don't get the incentive dollars until you've set the system up, are using it properly, and then you get the dollars. So this is a sizable investment. It's also an ongoing investment. Softwares are always upgraded. There are always licenses to be renewed every year. There's equipment that needs to be replaced. There's staff turnover that need to be trained again. So there's an ongoing cost, which on the low side, some people estimate you could get away with maybe a couple thousand a year per provider. In more complicated healthcare systems, they're probably spending over $50,000 a year per provider to maintain the system. Where's that going to come from when the $44,000 is spent? And I think that's one of the nasty questions out there is if you build it, can you sustain it? If we don't figure out how to make our practices more efficient by using electronic health records, we are not going to be able to afford these kind of systems. So it really is imperative, even beyond what the government thinks of or defines meaningful use as. I would add another nuance to say that another nuance of meaningful use is figuring out how to use it in a way that reduces your cost of care so that you can save money, have a better margin, or get a better rate from an insurance company because you're a more efficient provider. However that plays out, somehow the system needs to generate some revenue, and that revenue needs to go back to the doctor. So the insurance company can't be the one that pockets the efficiencies that we provide the system. They need to, and I'm not talking about necessarily Medicare, I'm talking about the entire third-party payment system, needs to recognize that doctors cannot be expected to pay and run these systems for the benefit of the payers. They need to acknowledge when that's happening and give us reimbursement for that. And in turn, practices need to take that extra reimbursement and not just sort of distribute it as income. It needs to be retained and spent on maintaining the infrastructure. So I think that we need to understand that there's an aspect of our business model, whether you're a small practice of 2 doctors or a bigger practice or a multidisciplinary clinic practice, whatever system you are, there's a financial burden here, and there needs to be a way to find the support for that.
Dr. Yu, it was great to spend time with you, and thank you for sharing your insights.
You're very welcome. It's my pleasure.
So I always say this at the end of every podcast, but please do take a look at the entire JOP issue. For July, there are 12 very interesting and diverse manuscripts as part of the EHR thematic series, as well as our regular journal content. In a future podcast, we'll be summarizing some of the additional articles. And as always, please send feedback about these podcasts to jopeditorsdesk@asco.org or comment in iTunes. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for listening.